Hello, Vet Vaulters, and welcome back. We're back with our second clinical episode with Professor Bruce Parry, with part 2 of Practical Guide to Diagnosing Coagulopathy. Today, we are looking at secondary coagulopathy, including that seemingly complicated and confusing thing called the coagulation cascade. Bruce gives us the most simple and memorable explanation of that Y-shaped beast that I've ever heard, and we will learn how and when to use tests of secondary coagulation, that is the activated clotting time, APTT and PT, in a way that finally makes perfect sense. We'll go deep into the weeds of the most commonly seen causes that will disrupt the coagulation cascade, and Bruce also clarifies some of the unusual suspects, the congenital factor abnormalities.
Head to heska.com.au to check out our sponsor for the episode and find out how you can not only pay about 30% less for your in-house lab consumables than you probably do now, but also get their high-quality analyzers for free. That's $0. Better yet, check out heska.com.au/vetvault to access the special offer that they have available exclusively to our listeners for $5,000 worth of free consumables. And head to our webpage at thevetvault.com to check out the show notes, where I've created a neat little summary for you on the content of these clinical episodes that you can refer back to at a later stage. Now, back to Bruce. All right, so we've covered platelets, buccal mucosal times. What else? What else have we got at our fingertips?
I think the next thing to contemplate then is it a problem of the coagulation cascade? And common things occur commonly, and the most common problem that you're going to get of the coagulation cascade is going to be a rat sac poisoning. So if your history was one of potential rat sac poisoning, while I would look at a blood smear for platelets, I'm really thinking I better do an APTT and PT. Or in an emergency setting, if you don't have access to that sort of equipment, then an activated coagulation time, an ACT. And I'm quite a fan of in-house ACTs. I think they are again a crude test, and you need to interpret them carefully. But if you have a dog or a cat that has come in bleeding excessively and it's rat bait poisoning, its ACT will be prolonged. Mm-hmm. No doubt about it.
So is there an advantage or a disadvantage between using an ACT or one of the in-house APTT analyzers?
It's always better, I think, to use the most sophisticated test that you can. That's at your fingertips, and these new in-house analyzers are certainly excellent for doing APTTs and PTs, and it gives you a lot more information.
I must admit, I'm a classic ACT man. You just got to feel for it, it's not high enough to cause bleeding. Where if you get APTT PT, it's like it's elevated. I don't know what that means now.
Well, hopefully Bruce can tell it, because that's my. So we used to have, before we got an in-house analyzer, everything was ACT. Snakes as well. We'd always check those. So I was quite used to it. And then we got the machine. So we totally abandoned the ACT. But then you pop up with those ones where you go, that's a bit high. Yeah. Is it a problem or not? So
it's like I haven't developed my own internal like buffer where it's like it's a little bit high. It's not enough. So I don't know if you've got any insight there, because that's why I still stay with ACTs.
It's tricky. You probably need a value to be 25% more than you consider normal for it to be clinically important. And while the analyzers will come with an inbuilt reference range, it's always nice to be able to compare them to a control as well, because the control is a double check on the accuracy of the instrument. Anybody can produce a number. Was that number produced properly? This goes for clinical chemistry and hematology as well, that you should be running controls every now and again on your clinical chemistry machines to make sure they're functioning properly. In a referral laboratory, they'll be running their controls with every single batch of tests that they do. Now, in practice, we don't do that. We rely on these instruments probably a bit more than we should. but I'd be encouraging you to run some sort of control through any of your machines periodically.
Okay.
Now, I realise that's a big ask in practice, so I'd just be suggesting look at your reference range, perhaps look at the middle value of that reference range, and if your patient is 25% above that, then that's probably prolonged. Go looking for a cause. And then it depends whether you've run an ACT or an APTT and PT together, what you're actually assessing. If you think about the coagulation cascade in its most simple form, you remember it's got a Y shape. It's got two arms that come into a centre point.
Yeah, that's about all I remember.
Yeah, well, that's all you need to remember. Everything else just follows logically. So your left arm is the longer one in the coagulation cascade. There are 4 factors in the left arm, and there are 2 factors in the right arm. In the left arm, we start with factor 12, and then it's 11, 9, 8. That's called the intrinsic pathway. It's the longer pathway, so it's assessed by the longer acronym. So it's the APTT that assesses the left arm. Now, it's easily remembered because you go down the street to buy something and they say, this is going to cost you $11.98. It's rounded up to 12.
Okay, cool.
Right?
Okay.
No 2-cent coins.
Rounders, yep, cool.
$11.98 rounded up to 12. You've got your intrinsic pathway.
Yeah.
Excellent. Okay.
The extrinsic pathway is on the right-hand side. The shorter pathway, there's only 2 things in it, and only one is important.
7.
Yep, 7 is important. 7 gets activated by factor 3. Factor 3 is tissue thromboplastin, and that is in every cell in the body. You are nobody if you don't have factor 3. You cannot be deficient in factor 3. So that's all we need to worry about. In the extrinsic pathway, factor 3. When we run a PT, the shorter acronym, prothrombin time, we add tissue factor 3, into the tube to set it off. And that causes the reaction we know as the prothrombin time, the PT. Okay, so extrinsic pathway, factor 7, that's it. Then you come into the common pathway, and there are again 4 factors in this pathway, and they're harder to remember. But the bottom one is factor 1. That's fibrinogen. The next one is factor 2. So 1, 2, easy enough. The next one is factor 5, and 2 5s are 10. So that the first one in the common pathway is factor 10. Now you've got your coagulation cascade memorised.
Easy.
Okay. Now, the reason then we need to know this is the ACT and the APTT both assess the intrinsic and common pathway. The ACT is the poor man's test, poor person's test. I mustn't be sexist.
Okay.
and that's because we simply add blood to a tube, and that tube has a grey powder in it called diatomaceous earth, and that activates factor 12.
Okay, and it stops off.
And then it just goes down the cascade. All right, so if you have a long ACT, you've got a deficiency of 1 or more of those 8 factors, 12, 11, 9, 8, 10, 5, 2, 1. It's a dog that's mature age, come in late at night, bleeding, that's going to be rat bait or snake bite or something like that, probably rat bait. And, of course, you've got your clinical examination, so you know if it's showing signs that might be consistent with snake bite, that's what you were screening for in the first place, or you might have a history of access to rodenticide or whatever. The caveats with the ACT are that it requires a pretty significant deficiency of clotting factor to prolong the ACT. But if the animal has a clinical coagulopathy, it has such a significant deficiency.
Okay.
The ACT would be not the test to perform if the owners come in with their dog and the packet of rat bait and the dog's not bleeding and they say, has my dog eaten this rat bait? Is it going to have a problem? The ACT won't answer that question. It will tell you if the dog has a problem, but not if it's going to have a problem.
Okay.
Now, what the things that can prolong the ACT are a deficiency of any one of those 8 factors individually, or the combination that you get in rat bait poisoning. And I'll come back to that. But the other thing that you do always need to be careful of when you run an ACT, if it's prolonged, go back to your blood smear and look for platelets, because severe thrombocytopenia prolongs the ACT. And the reason it does that is because platelets are a surface upon which factor 8 and factor 5 work optimally. So if you have a blood sample without platelets, those factors don't work properly and the ACT will be prolonged.
Okay.
But we're talking, again, profound thrombocytopenia. Okay. So down around 5, 10 by 10 to the 9 per litre. Okay, so if you've done your platelet count to begin with, you've ruled that out. If you haven't, go back and do it just to make sure that wasn't the cause. And then the individual clotting factor deficiencies are much less common than an acquired one of any kind.
Let's go back to rat bait for a second again. So just to recap, where does rat bait act? What are we going to see on our PT, PTT if we have a rat bait dog?
Okay, so your rat baits are almost always a vitamin K antagonist, which means they affect the vitamin K dependent clotting factors. They interfere with the final step in their production in their pre-active form in the liver. The vitamin K dependent factors are 2, 7, 9 and 10. So when you get a rat bait poisoning in your intrinsic and common pathway, you've got 3 of those 4 factors that are going to be deficient. So that's why the ACT will be prolonged. Now, the advantage of doing an APTT and PT together are that in very early rat bait poisonings, factor 7 is the first factor to disappear, okay? And that's because factor 7 has the shortest half-life in the circulation. Okay. Why is that important? Because the vitamin K antagonist poisons interfere with the production of clotting factors in the liver. So that as the animal first gets poisoned, it's still got plenty of clotting factors in the blood. That's why there's a lag between ingestion of the toxin and development of a coagulopathy. The clotting factors have to be used up in their normal daily happenings. They get degraded. And factor 7 has a half-life of about 7 hours. And if we assume an animal starts with 100% of a clotting factor, then in 7 hours, the level would be 50. If we stop production immediately, and we don't, but let's assume that we could, at 14 hours, you might be at 25%. And it's at around about 25% that you start to get a prolongation of your tests. Okay, so it should always take at least half a day between ingestion and development of clinical signs. Probably more, probably a day or maybe 2. And it depends on how much the animal ingested and whether it was a first generation or a second generation. And the first factor to disappear will always be 7. So the first test to prolong is the PT. If the person's brought in their animal and they reckon it has eaten it but it's not bleeding, I wouldn't be doing an ACT. I'd be doing an APTT and PT, or at least a PT on its own. And if the PT was within reference limits, that doesn't exclude the dog from having eaten the rat bait, but it does say at the moment it's not developing clinical signs.
Okay, so if we're going to check for bleeding signs, Bruce, you're saying we should start checking at around about the 14 hour, let's say 24 hours after suspect ingestion. That's when you should be checking it.
Yes, I think, as Gerardo said, 1 to 3 days, and it's going to depend on you as a clinician, whether you're how risk averse you are.
Yes.
And if you do it at 24 hours, bear in mind that you might be doing it too soon. So you'd probably be well advised to do it again at 3 days.
Yes. Okay.
And if at 3 days it's not prolonged,
Yep.
you probably are okay.
Yep.
It will never be prolonged.
Okay. Excellent.
So that approach might save you from giving it vitamin K. But then there is nothing wrong, as far as I can see, in just saying, well, yes, it's eaten the rat bait, let's give it vitamin K, other than how long do you treat them? And with the first generation, it's 2 weeks. With the second generation, it's 4-5 weeks. And that can be expensive for a big animal.
Well, one thing you said there, Bruce, and it's something that I've fall back on all the time, when you have these severely coagulopathic, right? So you were talking about secondary coagulation issues, and there's snake venom detection negative, right? Then you kind of think, what is it? What is it? And I always fall back onto that it's rat bait until proven otherwise. And they'll swear black and blue, there's no rat bait in the house. There's no rat bait in the house. But we always treat for rat bait and then continue investigating, but it's rat bait almost until proven otherwise. And I very rarely have I come across another form of secondary coagulopathy that's not like rat bait.
I think that's fine. I think that's a good approach. I probably am coming at it from a slightly different perspective, in that we get called in on the ones that you've just talked about that weren't rat bait, that had a prolonged APTT or PT. If you've got a rat bait poisoning, it should always have a prolonged APTT and PT. As long as the two are prolonged, I'm perfectly comfortable saying anticoagulant rat bait poisoning until proven otherwise, or you're never going to prove it otherwise. If the PT is normal, then you don't have a problem with 7, 10, 5, 2 and 1. So if the PT is normal, those 5 are okay, which means you have limited yourself to that intrinsic pathway, that left-hand arm.
And you categorically don't have rat bait. Dog's bleeding, but PT is normal, then it's not rat bait?
Yes. Yeah, as categorical as you can ever be.
Yeah, of course.
But, someone will prove you wrong at some point. But no, the factor 7 has the shortest half-life. It will disappear first. It will come back first as well. So if you start treatment and then you run APTT and PT, and the PT is normal, maybe it's your treatment that's already kicked in. So don't, collect, it's like anything. Collect your blood samples before you start treatment. Nothing wrong with empirical treatment. I'm a big believer in it. But don't then go back and collect the sample to try to prove the diagnosis after you've started your treatment. Because if a congenital problem of the common pathway, which is the other way you could get a prolonged APTT and PT, they're very rare. Very rare. I mean, factor 5 deficiency, to my knowledge, has never been reported in animals. It's rarely reported in people. And a factor 5 is one we if you find a case of that, you'd write it up, no doubt about it. But factor 2 and factor 1 and factor 2 deficiencies they're at that pivotal point in the coagulation cascade. If an animal is deficient in those 2 factors, it's probably going to bleed in the first few months of life, severely. Okay, so, they're not going to be a cause in an adult dog. Factor 10, much the same. Problems of individual factors in the common pathway are very, very rare. Then if it's just a prolonged APTT and a normal PT, as we said, you're looking at the intrinsic pathway. You've got 12, 11, 9, 8, and start at the bottom, start at 8, because factor 8 deficiency is haemophilia A, and haemophilia A is the most common inherited disorder of the coagulation cascade in animals and people. Prolonged APTT, normal PT in a reasonably mature aged animal, almost certainly going to be haemophilia A. If it's not factor 8 deficiency, it's going to be haemophilia B, factor 9 deficiency. And if it's not 9, it will be 11, haemophilia C. I said all this is so easy once you break it down. 12, 11, 9, 8, A, B, C. Factor 12 deficiency is it rarely occurs and is rarely clinically apparent. So we tend to think that animals with factor 12 deficiency go through life uneventfully. Probably don't even see them. And congenital factor 12 deficiency has been reported sporadically in cats with no clinical signs. So, and birds don't have factor 12. So, you can get by without factor 12 because you activate factor 11 when you have a problem. So factor 12 is pretty redundant as a factor.
So is that the one you mentioned in cats, Bruce? I've come across cats that have consistently raised APTT so I'll give you the case that first brought it to my attention. Is we had a snakebite cat and we were measuring or monitoring clotting times, and the APTT just wouldn't come down. We're like, well, the cat's completely normal, it's not coming down. And then I came across this, somebody said some cats have prolonged APTT, and is that factor 12 then? Is that what we're talking about?
That's what we're talking about. Yeah. And the first case I saw was first animal I saw with factor 12 deficiency was one we were using as a control cat for another cat that we thought had a coagulopathy. Okay, so when we ran the tests, we got the control cat as prolonged and the patient as normal. And of course, I went back to the clinician and said, "You dope, you mixed up the tubes." And they said, "No, we didn't mix them up. You did in the lab." So we chose to disagree on that and reran the tests on fresh samples, and it was the same.
Wow.
So this poor control cat it had factor 12 deficiency.
So Bruce, if I think I have a dog with a congenital coagulopathy, so factor 8, 9, or 11, and I say dog, is it always dog, or are we talking about cats as well?
Not always dogs, but much more common in dogs and cats.
So then I go, okay, I think it's that. What's my next step? Do I send it off to you to look at?
Yeah, if you think you are dealing with a congenital coagulopathy of a single factor, then you need to send it to a referral laboratory for a specific factor assay. And it should be a veterinary laboratory, not a human laboratory, because factor levels are different in different species, and you need to have a species-specific control to compare your patient sample to. So if you've got a sample from a dog, you've got to have a normal canine pool to relate back to. And they'll be able to measure specific clotting factors for you. So 8, they start with 8 if it's a prolonged APTT. If factor 8's normal, they'll try 9. If 9's normal, they'll try 11.
Bruce, that was super cool.
Thank you again, Bruce, for your time. That was extremely useful. To the listeners, I am going to try and make some show notes about this because it's lovely to listen to this and you go, yeah, I've got that. And 2 days later, out the other ear again. So we'll make some show notes so you can actually refer back to it. Check out our website at thevetvault.com and we'll see you again next time. Thank you, Bruce. Good night.
Thank you. Pleasure.